On this right temporal bone, we'll be demonstrating dissection for inside-out mastectomy. Anterior, superior, posterior, inferior are labeled. EAC denotes your external auditory canal. MT denotes the mastoid tip. This is the right temporal bone. Our first musculoperiosteal incision are same as for cortical mastoids. One incision is along the posterior superior canal wall. Another incision is along the temporal line. Hence we elevate a triangular shaped musculoperiosteal flap exposing the cortical mastoid. It is important that you practice this step on cadaver, but before starting the dissection, remove all the soft tissue from the lateral surface of the bone so it becomes easier to dissect and the soft tissue doesn't come in your way when you're drilling the bone. Soft tissue from the lateral aspect of temporal bone has been removed. Anterior, superior, posterior and inferior are labeled. S stands for spine of Henle. EAC denotes your external auditory canal. As in live surgery also, we elevate the tympanomeatal flap lateral to the annulus, just lateral to the annulus. Hence, in the same manner, with the help of a circular knife, give a circular incision just lateral to annulus and elevate the tympanomeatal flap from the external auditory canal. In dissection, I would advise that you remove all the skin from 360 degrees of external auditory canal so that there is no soft tissue coming in your way when you are starting your dissection. First, we will demonstrate how to collect the bone dust. Use a good cutting burr with minimal amount of irrigation. Only drop by drop of irrigation is required. And you start drilling on the lateralmost aspect of the external auditory canal. Keep widening the external auditory canal in 3/4 circumference with minimal irrigation. So you can have bone dust all around your external auditory canal, which can be then taken up by with the help of a Freer's elevator and kept on the side of a bowl. So you can use this bone dust at the end of procedure for cavity obliteration or some reconstruction procedure. In live surgery, when you are collecting the bone dust, be very particular that you collect it from a healthy part of the bone and not from the bone which is close to cholesteatoma sac. So that's the bone dust collected. Once the bone dust has been collected, you continue with the drilling. In inside-out mastectomy, your drilling is always in a circular manner so that you keep your canal circular all throughout. So first widen it on the lateral aspect and then go medially. The basic concept is that you follow the sac from where it starts, that is from the attic area, that is the area from where your cholesteatoma sac starts from, and then you follow it to its end. It can go up to attic, it can go beyond attic, up to antrum or to the mastoid cavity. But your end of dissection is, in live surgery, is determined by the end of your cholesteatoma sac. Here we have widened the outer part of the external auditory canal. Now with the diamond burr, we are widening the innermost or the medialmost aspect of the external auditory canal. Be careful when you are widening this part, as your rotating burr should not touch the ossicles, or else it may lead to some inner ear dysfunction if your incutastapetal joint is intact. Your direction of drilling should be medial to lateral so that even if your burr point slips, so it will come out and it won't hit any important structure in the attic. First structures to be seen are incus, malleus. You can see a glimpse of chorda tympani here. Horizontal part of facial nerve will be in depth out here. Again, you can see malleus and incus labeled as M and I. C stands for chorda tympani. H shows the handle of malleus attached to the tympanic membrane. Now your attic is partially exposed. Now you can further expose it by drilling medial to lateral and in a circular manner. So you have to keep your cavity circular all the time. First widen the lateral part of the cavity and then go medially. On the lateral aspect you drill in a circular manner, whereas when you are drilling on the medial aspect you drill from medial to lateral. So only our middle part of the attic is exposed. Attic is not yet completely exposed. So we'll drill further to expose the attic completely up to the anterior attic. First we are drilling the lateral part and then drilling from medial to lateral. There should be no any bony overhangs in the external auditory canal. That's the area of anterior buttress. If your cholesteatoma sac is limited, then limited to attic or up to antrum, then you can preserve the anterior and the posterior buttress without compromising on the sac removal, because these will help you when you are trying to reconstruct the attic or the antrum with the help of a cartilage. These give a sort of support on the medial end to the cartilage used for reconstruction of attic. We'll be showing you that in the same video. We are maintaining the medial end of the anterior buttress, but otherwise our anterior attic wall and the anterior canal wall are in the same line. There are no bony overhangs seen. The size of burr used is largest for that given area. You can use a cutting burr or a diamond burr, whatever you are comfortable with. But close to any structure, prefer to use a diamond burr. If you have any bony overhang obstructing the vision of anterior or inferior part of annulus, that should be drilled off so that you can visualize your bony annulus completely. It also helps in your post-operative follow-up of the patient. Note that my anterior attic wall is parallel to my anterior canal wall. There is no bony overhang or there is no bulge in between these two walls. Although on the medial end of the wall there is a anterior buttress lift which we like to preserve in case there is a small cholesteatoma limited to attic, which will help our reconstruction. So now we have nearly exposed our complete attic. A stands for your anterior attic, M denotes malleus, I denotes your incus, body of incus, S denotes the short process of incus, which is not completely visible right now. There is some bony overhang still over it. H denotes your head of malleus. Now we will continue our dissection. There is still a bony overhang up at the anterior end of the attic. So we'll remove that bony overhang so that we can visualize the anterior attic completely. Then we'll go posteriorly and expose the antrum. If you're trying to preserve the anterior buttress or the posterior buttress so that you can use it at the end of surgery for reconstruction, should always keep in mind that its presence is not compromising your sac removal, cholestoma sac removal. If it is compromising the vision or if it is compromising the sac removal, then you should remove the anterior buttress completely. That's the anterior attic completely exposed, and you can connect your anterior attic from there via supratubal cells to the eustachian tube. That's your anterior ventilation pathway. That's the anterior buttress. That's the posterior buttress. You can elevate part of tympanic membrane to visualize the structure still better in that area. Dissect the chorda tympani of the tympanic membrane without stretching it, because even stretching the chorda tympani will patient will end up in some taste disturbances. Appreciate the chorda tympani nerve marked by C, and your P denotes the processus cochleaformis. A tweak of tensor tympani muscle arises from takes a turn from processus cochleaformis to go and attach under the neck of Melius. Now we continue our dissection for exposing the antrum. Again, as discussed earlier, first widen the lateral part of cavity in a circular manner, and then go in for widening the medial part of cavity. And when you're widening the medial part of cavity, your direction of drilling should be from medial to lateral. The basic concept of cholestoma surgery when you are doing an inside-out mastectomy, always remember, is that you start the dissection from where the disease starts, that is from the attic, and you follow it up till the end of the disease. After you have reached the end of the disease, that is end of the cholestoma sac, you remove the sac in a single piece. You don't have to remove it in bits of pieces. Remove it in a single piece, and then you can obliterate the cavity or reconstruct it, or you may end up with the canal wall down also. So it is not essentially, and the end result is not always essentially a canal wall down. It can be a canal wall up if you reconstruct it. Appreciate that always my cavity is always circular. The whole canal looks circular. I have reached the antrum, but still the whole canal looks circular. One more advantage in doing an inside-out technique is that before even starting the surgery, your facial nerve is under vision. You can follow the facial nerve from its horizontal segment, going to second genu and going into vertical segment. So your best landmark is your horizontal segment of facial nerve. Obviously other structures are a landmark, but when you are doing an inside out, you have the facial nerve in vision at the very starting of the surgery. Now that's our antrum exposed. That's the lateral semicircular canal bulge seen partially. That's the incus. You can elevate the tympanic membrane to visualize the middle ear structure a bit better. You can see a thin nerve over the promontory. That's a branch of tympanic plexus coming. This goes and joins the lesser superficial petrosal nerve to form the nerve of Vidian canal. It is denoted by N in this frame. P denotes the promontory. C denotes your chorda tympani nerve. L denotes the long process of incus. I denotes the body of incus. A denotes the antrum. Appreciate the horizontal segment of facial nerve, which is more whitish in color, denoted by F, and which is medial to the long process of incus. So when you are starting your inside-out mastectomy, always remain lateral to ossicles, specifically incus. So that way you will always preserve your facial nerve. because your facial nerve is always medial to ossicles. Now this completes our echoantrostomy. If your cholesteatoma sac is going beyond the antrum, then we need to continue drilling beyond the antrum and go up to the end of the sac as discussed earlier. Again, even in this part, like in everywhere else, first drill in a circular manner on the lateral part of the bone. Remove the cortical thicker bone in a circular manner and then go in medially to remove the most cellular bone. When you're drilling on the medial aspect, prefer the drill from medial to lateral. You have couple of landmarks in your vision. Your ossicles are in the vision. Lateral semicircular canal, although the whole bulge is not seen, but uh, you could see a little bit of curvature of the lateral semicircular canal. You can visualize the chorda tympani nerve is seen. So with these landmarks in picture, we start removing cells from the mastoid cavity. Once we have gone beyond the antrum, the dissection is more like of a cortical dissection, that you remove the cells and then keep going posteriorly. You can follow the tegment plate also, going in the to form the floor of the middle cranial fossa. At any point of dissection, try and appreciate that my cavity is always circular and there is no bony overhangs anywhere in the cavity. That is how you need to keep your cavity even in life surgery. There should be no bony overhangs and your cavity should be circular as far as possible. Follow the cells and remove all the cells in dissection and preserve a thin plate of bone over the underlying important structures such as sigmoid sinus, middle fossa dura, digastric ridge, fallopian canal, and etc. Now your basic concepts of cortical dissection will also apply as we are in the mastoid cavity. After drilling the more cortical bone, the lateral cortical bone, now we are drilling the most cellular bone of the mastoid cavity. Our aim is to remove all the cells of the mastoid cavity so that the underlying structures stand out with a thin shell of bony covering over them. That we are drilling for the mastoid tip cells. Those are the lateral tip cells being drilled. Once we remove the lateral tip cells and the medial tip cells, our digastric ridge will stand out. Now those are the cells lateral to sigmoid sinus and medial to digastric ridge. These will go for medial tip cells. Once we remove these cells completely, our digastric ridge will stand out. You can see our digastric ridge coming up. We can follow the tegment plate from the attic and follow it in the mastoid cavity. Remove all the cells over the tegment plate so that a thin plate of bone is left behind, covering the middle cranial fossa dura. M denotes your malleus, I denotes your incus, DR denotes the digastric ridge, MT denotes the mastoid tip. There are still some cells left in the lateral mastoid tip. SS denotes the sigmoid sinus. There are still some cells over the sigmoid sinus and whole of the mastoid cavity, which we need to still remove. Those are the lateral tip cells being drilled off. Simultaneously lower the facial ridge. So we are not leaving the facial nerve for the end of this section. As we are going another part of mastoid cavity, simultaneously keep lowering the facial ridge also. So at any point of dissection, you will not see a ridge standing out. For drilling on the facial ridge, keep in mind that about the position of your horizontal segment of facial nerve, which is easily seen once you complete your epicotomy. That we are drilling over the labyrinthine block. There are still lots of cells over the labyrinthine block and the pre-sigmoid dura. That's the sinusoidal angle we are drilling in. You can use a large size diamond burr to remove last bits of cells. Now we are drilling over the sigmoid sinus to remove last bits of cells. Polish the whole cavity with a large size diamond burr so that no cell is left behind and you see a thin, uniformly thin plate of bone over the all important structures. When you're drilling in the retrofacial area, be careful that your burr point doesn't damage the facial nerve from its undersurface. That's the retrofacial area being drilled. Those are the lateral trip cells being removed. Now we are drilling in the sinusoidal angle. That's a pre-sigmoid dural plate. Again, when we are drilling in this area, we are drilling from medial to lateral direction. Those are the cells over the labyrinthine block which are now being drilled. Try and appreciate the color difference between the bone of the labyrinthine block and those of the cells which are present over the labyrinthine block. They look totally different, but try and appreciate the color difference under the microscope. As in cortical dissection, for removing the cells present in between the semicircular canal, you will have to shift to a smaller size burr point, about 2 to 3 millimeter size burr point. In this bone, there are lots of cells in the squamous portion of temporal bone extending in the mastoid cavity. Hence, we're using a larger size oblong conical burr, cutting burr, to remove those cells. Even in the lateralmost aspect, first remove the cortical bone and then go for medially more cellular bone. Now with this large size diamond burr, we can polish the tegment plate. When you are polishing the tegment plate, as in anywhere in the mastoid cavity, see to it that you maintain a evenly thin plate of bone. It should not be that it is thin at some places, it is thicker at other places. It should be uniformly thin at all the places. Most of the cavity is smooth. Your MFD denotes middle fossa distal plate. SDA denotes the sinoidal angle. SS denotes the sigmoid sinus. PFD denotes the posterior fossa distal plate. JB denotes the jugular bulb. DR denotes the digastric ridge. LB denotes the labyrinthine block which still have lots of cells around it. M and I denotes malleus and incus respectively. Incus is dislocated and being removed. We are using a smaller size burr point to remove the cells around the labyrinthine block. Our aim is to remove all the cells between the three semicircular canals so that at the end of dissection we can see the three semicircular canals separately standing out. Whenever in drilling you have doubt, stop the drilling, go under higher magnification and visualize the structures. Orient yourself anatomically. These we are drilling the medial tip cells. You should be drilling in a low magnification so that you have better anatomical orientation, as you will be able to see more structures, more surrounding structures. But whenever in doubt or in time to time while drilling, go under high magnification, observe the structure, come back to a low magnification and drill. Now elevate the tympanic membrane in the posterior segment. In live surgery, this step will depend upon the extent of cholesteatoma. If the cholesteatoma is going in sinus tympani, lower the facial ridge, drill along the length of vertical segment of fallopian canal. Your drilling should always be parallel to the facial nerve. Match the floor of external auditory canal to the floor of mastoid cavity. Although in this case it may not be possible, as your mastoid tip is going much lower to the floor of external auditory canal. In live surgery, if you have such a situation, then you will need to obliterate this cavity either by excising the mastoid tip or by filling this cavity with muscle, cartilage, bone pate or any artificial material available. We are not only drilling over the facial nerve, we are also drilling anterior to the fallopian canal. This step of drilling is known as thinning of facial ridge. By this step, we will able to visualize the sinus tympani completely. Remember that the distance between the vertical segment of fallopian canal and the bony annulus is at least 3 to 5 millimeters. So that is the amount of bone which you can remove anterior to the fallopian canal. When you're drilling in this area, you need to have copious amount of suction irrigation, as the heat generated by the rotating burr itself can lead to thermal damage and postoperative facial nerve paralysis in these cases. Keep your horizontal segment of facial nerve in the view. We can see the horizontal segment of facial nerve, our pyramid and stipital tendon. When you are close to a facial nerve, switch over to a diamond burr and drill parallel to the facial nerve. Now we are drilling anterior to the facial nerve, that is known as thinning of facial ridge. This is a very important step to gain access to sinus tympani, which is a common area for residual cholesteatoma. There's still some bone behind the vertical segment of facial nerve, which is being removed. You can appreciate the vertical segment of fallopian canal or the facial nerve as whitish color under a thin plate of bone. When you are drilling in this retrofacial area, be careful, specifically when you are drilling in a more medial aspect, because your burr point can damage the facial nerve from its undersurface. Also, the ampulla of the posterior semicircular canal comes in this area. So when you are going a bit superior, be careful. Try and appreciate the color difference. The bone over the labyrinthine block, the bone over the posterior semicircular canal and the lateral semicircular canal is more ivory in color, whereas the cells which we are drilling are more reddish in color. So F denotes the vertical segment of fallopian canal, FH denotes the horizontal segment of facial nerve, P denotes the pyramid from which a small twig of stipital tendon is arising, which will go and attach in the on the stipital head. Our sinus tympani is completely exposed, which is anterior to the vertical segment of fallopian canal. There's still some bony overhang in the hypotympanic area, which is now being drilled. Now we are drilling in the retrofacial area. That is the undersurface of vertical segment of fallopian canal. Be careful in this area, as your bone over the jugular bulb is very thin and can easily be damaged even in live surgery. That's anterior, posterior, inferior and superior. That's the tympanic membrane. That's the tegment plate, sigmoid sinus, sinusoidal angle, digastric ridge, mastoid tip. The level of mastoid tip is lower than the level of the floor of external auditory canal, so which we need to obliterate at the end of surgery. That's the lateral semicircular canal, superior semicircular canal, and the posterior semicircular canal. That's the jugular bulb. Now to see the middle ear structure, that's cauda tympani. You see the nerve plexus over the promontory. That's the stapedial head, stapedial tendon, round window. That's the pyramid. That's the horizontal segment of facial nerve, going in for vertical segment of facial nerve. Again the same structures labeled. F stands for horizontal segment of facial nerve. FV stands for vertical segment of fallopian canal. PY denotes your pyramid. The star is labeling the stapedial head. R denotes the round window.